Today we're here with Shirley Russell. Shirley has a master's degree in psychiatric nursing. She also has 24 years experience in working in hospital-based psychiatric settings and chemical dependency treatment centers, as well as in home-based counseling work with individuals and families. And for the past 6 years, Shirley's been working at Midcoast Hospital in Brunswick, Maine in their Outpatient Addiction Resource Center. Thank you for being with us today, Shirley, and for sharing with us your expertise. We really appreciate that. Can you tell us a little bit more about opiate dependence and the community health crisis that we're facing in Maine?
Well, first of all, Maine has the highest per capita opiate dependence in the whole country. Actually, Maine and another state, West Virginia, right now are the top two states, but usually it's one or the other. So it is a big public health problem in the state of Maine. And it is getting more attention now, but there's still a lot more we need to be doing. As far as treatment goes, we're seeing many more people presenting with opiate dependency as their primary addiction, even over alcoholism now. They're pretty close, 44%. This is in a 2010 study by the Maine Office of Substance Abuse. It was found 44% of people presenting for treatment are opiate dependent and 41% alcohol. So it's really, the primary addiction that's being treated right now.
How did this happen? I mean, do you have some thoughts about that?
Yeah. There's probably numerous factors, but one that is being addressed right now is the prescribing of opiates for pain and the appropriate use of opiates, but how the prescribing maybe has gone on for prolonged periods of time and been done more freely than really may be appropriate, especially with the high level of dependency that opiate use causes. And so over time, people get dependent and even addicted to their opiate prescriptions that they're legitimately getting for any healthcare issue. And then if they start to overuse their medication, which happens in addiction, and their physicians find out that they're running out too early, and then they get concerned that an addiction has happened and their patient may be behaving in an addictive manner, they get discharged, they get cut off from their prescriptions. And then you find people out seeking other ways. Withdrawal from opiates is quite uncomfortable and can go on for a week or longer, and the cravings can go on for much longer than that. And so people are out looking for other ways to get their opiates, and then it's illegal ways of obtaining their substance. So that's a big part of it. And because of so many people having opiate prescriptions, it's not uncommon for them to share them with their family members or to have them accessible in their medicine cabinet. And now youth and young people are often borrowing and taking their other family members' prescriptions, and they're abusing them and becoming dependent, and that's feeding further addiction development. And you also have along the New England coast versus the West Coast, there's a lot more amphetamine use. On the East Coast, there's more opiate use and dependency, and we have close suppliers of other opiates such as heroin coming up from Boston and New York, and it's quite inexpensive. I mean, right now I'm told heroin is cheaper on the street than buying a illicit OxyContin on the street. And so there's also that supply and availability in the area that has contributed to the increased opiate dependence in the state of Maine.
So Shirley, these are troubling statistics and troubling information. Can you help us better understand the biology of addiction and maybe better understand some of these terms, opiate, opioid, Suboxone? Can you help us make sense of that?
Sure. So just a very brief explanation about addiction. I mean, in the last 25 years, a lot of research has shown about the changes that happen in the brain, the structural and functional changes that happen with addiction. And it's surprising how there's still such a belief in communities about addiction being a moral disease or a moral failure. Why can't someone just stop using and use their willpower? And what happens is we have a reward center in our brain. And so when we engage in any pleasurable activities, the reward center of our brain releases dopamine, a neurotransmitter, to help us feel good and to encourage that behavior. So usually it's behavior that we have as human beings to stay alive, reproductive, our sexual behavior, eating, being with people you love. There's naturally a release of this dopamine so that we will continue to have those behaviors and survive. So when you take mood-altering drugs, they also release that dopamine in the brain, but 2 to 10 times the normal release around pleasurable activities. And so the brain over time starts to recognize that substance, and this is where the cravings and come in. And you also get depleted of these pleasure-giving neurotransmitters, and then you go into periods of feeling maybe dysphoric or uncomfortable or depressed or craving that substance again. So over time, these cravings occur in the brain, and this obsessive thinking and craving for the substance of choice. So that could be alcohol, that can be opiates, it could be other substances as well. So it really becomes a brain disease. And even when somebody's treated and has a period of recovery, that the brain is just sort of in remission in that area of the brain, the reward center. It's just in remission. The next time you pick up again, you can go back to your addictive behavior just like that. It recognizes the substance is back. And so we're really, addiction's considered a brain disease, a chronic disease, and a disease where relapse is kind of to be expected over periods of time, even when people are working hard on their recovery. So when I talk about opiates, the term opiates is really used for the natural occurring opiates that come from the poppy plant. And so that's like morphine and codeine. And then there's many natural occurring opiates, well, actually synthetic opiates, like what you hear about OxyContin, oxycodone, methadone, Suboxone, or buprenorphine are synthetic opiates. So opioids is a term that encompasses all of those, the naturally plant occurring and also the synthetic man-made opiates. So when you hear that term, it's just more of an all-inclusive term, opioids. You mentioned Suboxone, and that's definitely of interest to people who have a opioid dependency, and it's becoming very well known as a medication that can relieve people's craving and withdrawals. As I mentioned in describing addiction, if you have an addiction, you're going to have cravings and different levels of withdrawals depending on how serious your opioid dependency is. But on that particular medication, like we'll focus on that instead of alcoholism and other addictions. But once you become addicted to opioids, it's pretty dramatic, and you are, because you become quite uncomfortable when you don't have that substance in your system. You're usually taking short-acting opioids, and usually 4 and 6 hours you're looking for another dose.
Okay, very helpful, very helpful. So Shirley, who's a typical person that presents to you for treatment and help?
Well, that's really a good question, because I think the community's idea of who has an addiction can be pretty stereotyped as well. And really, we see all ages and all groups of people coming in. It crosses, social and economic barriers. So anybody really presents. Mostly what I'm seeing where I work at Addiction Resource Center in Brunswick is younger people in their 20s and 30s often, and they may have gotten addicted from for different reasons, but often it's experimenting with drugs, which is, of course, very common, and maybe they've tried opiates and don't realize how quickly they can get addicted to them, and they find themselves addicted. This age group also, it's common to have people come in that have chronic pain issues. Like in Maine, there's several industries that we see people presenting from more commonly. One is the fishing industry. In the fishing industry, there's a lot, lobstering, there's a lot of back work, pulling lobster traps. There's a lot of physical work, clamming and all of that. And so there's often back pain and chronic pain that goes along with that, where prescription opioids have been started and over time addictions occur. We also see that in the building industries, again, because of the physical labor and the aches and pains and injuries that can occur. We see a lot more presentations from that industry where addictions then happen. And also from the restaurant business and the food industry. And that is more of like a social culture where often people are drinking and using substances and everyone in your environment's doing, and that's what you do commonly. And so it's maybe more of a social precipitant to becoming addicted. You're using recreationally or casually, and it develops into an addiction. And then we have the older population. We have people certainly coming in older. I mean, right through their 60s and on. They're often addicted for the same reasons that I mentioned, but maybe even more so from medical problems and issues that they've become dependent on. But it also can be, your social group. Who are you hanging out with? There are some workplaces where it's very common for people to be using opiates on their coffee breaks and whatnot, and it's well known, it's accessible, and it becomes normalized. Even within families, it becomes normalized. You have generations of families who normally use substances for recreation or to treat their ills, or it's just even for mental health reasons in distress. They're using opiates or other drugs. So it becomes socially acceptable. And you've got the genetic influence about addictions as well. There continues to be studies done on this, but usually when you do the assessments of people coming in for treatment and you ask about family history, it's really rare to hear that they don't have relatives, direct, even next, parents, aunts, uncles, siblings that also have dependencies. So there's, the genetic influence as well. But so there really isn't any typical person coming in, but we do see more the younger population right now. There may be a higher percentage in the 20 and 30-year-olds, and I think that's maybe true from this study that I mentioned that the Maine Office of Substance Abuse has done. So I'd like to say something about the priority populations as far as people coming in for opiate dependency treatment. One is pregnant women. In Maine, about 17% of pregnant women use alcohol or drugs. And so this poses a lot of risk to their unborn child, risk of birth defects, premature birth, low birth weight. So there's some serious problems. Also, miscarriage. If a woman who is dependent on opiates finds out she's pregnant and says, oh, I'm going to stop using, and then starts going through withdrawal, that poses a risk of having a miscarriage. So we really would like the public to know that if you're a pregnant woman and you're dependent on opioids, do not rapidly stop using opioids. Get yourself to a doctor or a detox center, because at the detox center, you're a priority population. They want you to come in. They will make sure that you don't go through withdrawal, and they can start you on buprenorphine, anti-craving medication, and stabilize you on that through the rest of your pregnancy, or the methadone treatment, either one of those, stabilize you through the rest of your pregnancy so that the unborn child isn't going through withdrawal and that you can have a safer pregnancy. And then be referred to treatment or referred to a hospital where they specialize in delivering and care for these new for these babies. So that's one priority population. The second one is intravenous drug users. Using intravenously exposes people to some pretty serious illnesses. Hepatitis B and hepatitis C are a couple, and also HIV. What I see in my practice is a lot of hepatitis C. a lot of hepatitis C, which is a liver disease, and over time can cause further health problems. So we really, that's a priority population. We want to decrease people's risk of disease. Also, you can get serious infections such as bone infections, heart infections from using intravenously, systemic blood infections. So that's really a priority population. We want to get into treatment, get on anti-craving medication to reduce any further risk of not only to themselves but to the public, because the more you're out there using needles or the different apparatus with needles, the more this becomes a public health issue of these diseases being spread in the community. And then the third population I want to talk about is people with mental health symptoms or mental health disorders that are often untreated. They often are picking up street substances to treat their symptoms, often anxiety, depression, it could be post-traumatic stress disorder, many other symptoms. And they're treating themselves but not really getting adequate, appropriate treatment for their problems. There's about 50% of the people that come for services have untreated mental health symptoms. So that's really an incredibly high number. So when people come for treatment, not only are they getting the counseling I talked about, they also get case management, referral to appropriate mental health providers that can, diagnose and treat those problems along in conjunction, and medical problems that are untreated and undiagnosed, along with the addiction disorder as well. So you're really getting a sort of a comprehensive healthcare assessment and referrals for treatment when you come into treatment centers as well.
Thank you, Shirley, for that really good summary about the nature of the problem of opiate dependence in Maine, how it's impacting the community. The biology of addiction was really helpful, and it really sounds like it could affect any one of us. When we get back together, we're going to talk a little bit about treatment, and if you could tell us where we could go for help and what our options are.